Hello, everyone. Hey, it's another great CCO Club webinar. We're on number 88. I can't wait for it to get to 100. We'll have to have some kind of special celebration. The CCO Club webinars, the focus of them are questions that come in, and then we kind of unpack the questions, give you more information about them. So these are questions that come in from our club members. And we have a lot of fun doing the research for these. If you want to become a club member, we'll give you more information at the end and tell you how you can submit questions or um, suggestions of things that you think would be beneficial to our peers and all of us in this industry. The question that came in recently was about grafts, flaps, and adjacent tissue transfers in medical coding. That specifically had asked about some guidelines regarding them, and they're not any particular guidelines, not like you would see in some other procedures that are done. However, I did go in and find some specifics about the details that separate grafts, flaps, and transfers. So we're going to break that down. We have done some presentations in the past, so I encourage you to go out to our YouTube channel, Medical Coding Cert, and look in there and see if you could probably just type in grafts or flaps and some of the other content that we've done in the past. Now, we haven't talked about this particular subject for a while, so pay attention to the dates because we've got videos almost a decade old in there, and for the most part, this area, I don't think there hasn't been any real significant changes in the code set, but just do keep that in mind as that is pertinent. Donna says this is a big plastic surgery procedures. Absolutely, it is. And another thing that I would tell you to do is go out and look at some different plastic surgery websites because it's hard to get some of these procedures under your belt or the knowledge, and they do a lot of pictures. Most surgery does some grafting and some other type of skin lesions that are removed, but it's much broader than that. It can be accidents, trauma, as well as even when somebody has an amputation, they end up kind of making a flap. I didn't go there, but that is some examples that you will be able to find. So let's start with grafts themselves. There are more than one type, and I'm going to bring to your attention some verbiage that I really think that's going to be pertinent. If you have your little notebook, you could write these down and do some more research. But again, if you're in the club, you're going to get a copy of this in the club, so you'll get the slide deck and the transcription as well as be able to watch the video. So for grafts, one of the thing, if they harvest tissue from your body, then it's called an autograft. Just like you sign your own name, it's an autograft. If it is from somebody else, but they are, a person, a human, then it's not a autograft. Put in the chat what it's called if you have a procedure, skin or something taking from another person, but not yourself. And again, if it's taken from you, it's called an autograft. If it's taken from another species, it's called a xenograft. Again, we've talked about grafts in the past, and you're probably pretty savvy with that, but I'd be real curious to see who knows what the term is if you do a graft harvested from another person. Christine has it. Elaine, Whitney, all have it. Michelle, allograft, ALLO. So if it's from you, so we take maybe a piece of thigh skin and we place it on a wound on the hand to seal that up, then that would be an autograft. And everybody's, man, you're nailing it. Great, guys. So ALLO, allograft, is it's from the same species. And so, again, they still have to do type and match and all kinds of stuff, but then you will take the skin or the tissue from somebody else and then use that. You have a donor site. A donor site is another term you need to be aware of. So if it's an allograft, it's a donor site, say from the thigh to uh, close some type of a wound, say on the hand or the arm. Now, uh, a graft more or less is a broad term that's stating, hey, we're taking tissue from a place that it exists and moving it to another place. Again, if you harvest it, that means that you're taking it, and there is a donor site. You would harvest from a donor site. The donor site could be from you, or it could be an allograft where it's from somebody else. And there's like tissue banks where they save, and you can even save your own tissue if they know you have to have a procedure done, and they have the ability to um, kind of feed and grow your own tissue. And Donna says, my knowledge comes from working with the department chairs at UTSW. That's pretty cool. Anytime you can take advantage of having the ability to broaden your knowledge base, that's fabulous. So again, now we've talked about harvest, donor, autografts, allografts, xenografts, and sometimes grafts are done for people who are burn victims. That would be the number one thing that I think of when I think of somebody having a graft is a burn victim. Number two, I think of, say, facial uh, procedure done on somebody that's had a melanoma removed or a squamous cell carcinoma. Because again, even though squamous cell is not malignant, it grows and causes complications and damage. So again, uh, grafts are a lot of times performed with burns and burn patients. And when you have 30% or more of total body surface area, then you're probably going to have a graft. Total body surface area, TBSA, that's another term that you need to have in your knowledge bank. So if you aren't familiar with that, make sure that you write that down. It is something that you're not only going to see with well, you'll see it in burns and other procedures, but when you're coding for burns, absolutely total body surface area is going to be used a lot. So if we're just doing a graft, say we're doing tissue cultured skin from an autograft, 15040 would be a starting point. And did with these, I'm taking one code. Then there is a lot of codes because it's based on the amount of space or size, like 100 um, SQs. Again, okay, so that gives you how the size, and then there's an add-on code that says an additional 100. Square centimeters is what that stands for. Notice 15040, the pertinent terms are that it is cultured skin autograft, right? And 100 square centimeters or less. That's important. Those are the terms for this. Now, use this 15040 to look at additional codes. Underneath that, that is the add-on code that says additional, you know, space. And if there is codes that talk about different body parts, we're going to see some of those. If you don't know the rule of nines, that's another thing that you need to have in your knowledge banks, because the rule of nines is kind of universal. Uh, uh, they also, you can put in TBSA and you'll get a lot of rule of nines type graphics if you're looking at those. But again, this is one for total body surface area. The chest and abdomen together, see, that's 18 because it's 9 and 9 is 18. So is the back. The head is 9. Each leg is 9. That's why it's called the rule of nines. Now, this is for an adult. They have one for children, adolescent, and pediatric, infant ones where it's broken down because again, a burn that's, say, a 4 by 4 size burn on an adult, compared to that same size burn on a child, an infant, is dramatically different, as you can imagine. Elaine says a few years ago, my son had a mass on one of his big toes and he was supposed to get one, but they didn't have to use it. Yeah, there is, sometimes they have to do grafts to repair, or because it'll build up scar tissue, and you could, especially on places that don't have a lot of give, you could end up with webbed fingers or webbed toes and stuff like that. So, okay, let's move on to the next. 15050 is a pinch graft. This is not one I was very familiar with. So when I was looking at the codes to share with you, I looked at that and I kept thinking, I don't think that I remember ever having seen a pinch graft coded or that term used. And I've been doing this a long time. So I went and looked and I thought, what actually is a pinch graft? And ultimately what it is they take this tiny little piece. Now there are some really cool vivid images of pinch grafts, but and usually I share those with you, but this graphic was perfect to explain. So they take just the tiny little piece of tissue, and then they will put that, maybe there's like an ulcer or something that they've debrided, the wound's kind of open, they'll put that on there and it'll just grow. It will, it's almost, I kind of thought of it like a scab. You put it on there and then it just slowly starts growing. But again, it has something to do with the blood supply is able to take over. I was really quite amazed. Again, let's talk about the code description. Pinch grafts, single or multiple. That's very important. Now, when they do these pinch grafts, they don't usually do just one. Some of the graphics that I saw in Google Images, they end up doing several of them. But again, it's because they're taking tiny little pieces, or I guess if it's a tiny little area that they have to graft in, maybe they would just use one. But they were talking about fingers and toes being areas that pinch grafts a lot of times are used. So single or multiple, it doesn't matter. So that means that if you ever see 15050 with a ×4, that's not going to be applicable, because single or multiple is in the description. It's to cover a small ulcer, tip of a digit, or minimal open area. Now, noticed in parentheses in the parenthetical, except on the face. So this is another area that I could see a classic test question coming in, as where they put they could even call it a pinch graft, but it's something else if they do it to the face, if they put something on the face. And then it says up to defect size 2 centimeters diameter. And usually it's the other way around, but this is up to 2 centimeters. So again, these are itty bitty tiny little areas that they're grafting. Important to note, single or multiple, and other than the face. Now, this is a description that came from Find a Code. We use them exclusively as our encoder because they are so educational based, and I like the descriptions that they put in there. It helps me understand. So I took a little bit of that out of that, and it said that the center of the pinch graft contains both dermis and epidermis, so they're full thickness, and that distinguishes different types of grafts, knowing how much, if we're just taking the top layer or if we're taking into the epidermis. And so that again, it ends up being full thickness, and the edges only can contain epidermis. So notice again, full thickness in the center, and then you're getting the edges are thin. I remember watching Dr. Sandra Lee, that's the pimple popper, but she does she's always removing stuff. And when she was removing skin tags, or sometimes a lesion that she'll kind of shave off with a scalpel, she said you never want to take it with a pair of tweezers or forceps and pull it up and then cut it off, because if you do, then it leaves a gaping hole versus just leaving it flush and removing it like you were slicing a little bit of butter is what I was thinking. And that resonated with me. And so again, what they would do here, though, it's different. If they're taking a pinch graft, they're pinching it, pulling it up, and then cutting it because they want to take that full thickness in the center. But if you're just taking off a skin tag or a lesion where you just want to take off the surface, you would not do that. So it explains why they call it pinch graft. Now, if they do edges that contain only epidermis, that's called split thickness, and we're going to be talking about those um, in a minute as well. So if the small area of skin is similar in texture to the defect area, that's what they'll use. Yeah, if you've ever seen people that had grafts, they try to pick areas that are similar. So again, you don't want a place on the top of your hand that has hair cells, or you'd have a hairy patch growing out of your arm or your hand, right? And vice versa. The Recently I was doing some research, and it was on amputations. I was doing a project for amputations, and I was noticing that people that lose their thumb, that sometimes they'll take the great toe or the big toe, and they would use that to replace the thumb so that you would be able to have that articulation of all of your digits on your hand and be able to grasp stuff. And the texture of your toe is not the same as on your hand. It's very, very similar, but it's not quite, or the shape. It's similar, but it's not. But it's about as close as you can get to a thumb, recreating a thumb. So go out and look at some of those. I thought that was interesting. Other grafts, that split thickness graft, that's called an STSG, and it's the entire epidermis and partial thickness of the dermis. Now, when they take those, I thought it was interesting to note that they like to take it from the thigh, buttocks, abdominal wall, or the scalp. Now, the scalp, again, you have to be careful because you're going to grow hair. The follicles will most likely survive, but that where do you have extra flesh, extra skin surface? The thigh, the buttocks, and the abdominal wall. So it would make sense that if you needed to replace skin somewhere, that's where they're going to take it. And they want to take skin that isn't stretched out and flappy. So they aren't going to necessarily take my abdominal wall. They probably take it from the thigh where you have more skin integrity. Age is a big component on doing grafts. I would think that there is a reason or a protocol that they go through with where they want to grab that graft. It's important to note that there's a number of techniques used to get your STSGs, those split thickness, and for you, you may want to, if you're going to be coding this a lot, go in, research the different techniques, because that's verbiage that you're going to see in your documentation. Now, I can tell you that the way that they harvest the techniques, a lot of times that's not designated in the description for grafts. You'll notice that by 15100, it notice it doesn't even tell you how they're going to take that split thickness autograft. Now, that isn't the case for the CPT codes are very, very descriptive, and there are some that do have that description in there, but a lot of them do not. So be conscious of that. So when you're reading that, that's fodder. That's not information that you really care about, how they remove it or harvest it. Um, and again, that might take the stress off of you when you have a really large case that you have to abstract from to be able to code for testing purposes. But again, the most common one they mention is called a dermatome, which is like this and looks like a really space age cheese slicer. And it more or less does the exact same thing as cheese slicer. So again, don't don't be confused when you see terms like dermatome. All right, now this particular graphic, it shows there's the donor site. So let's just assume this was the thigh. So they do their dermatome cheese grater, slice off the tissue, and they've got a nice, even edge that they've approximated. They're going to test that. Now, if you've never watched this procedure done, it's pretty fascinating. So they do such a thin layer a lot of times that it just scabs over, right? They're not going super deep. They can adjust how much they need to go. But I've seen some people that have had this done, that I've known that's had it done. A particular person, she had throat cancer, and they went in and took out her um, um, vocal cords and some other things, and they ended up having to take a lot of tissue here, so they had to do a graft. And they did their first graft, and then they went back and did some other grafts, and they took the top of her thigh, and it just looked like she had road rash as it was starting to heal, because they'd taken it, literally looked about the size of a sheet of paper, notebook paper. And then that was all grafted in to help seal that up properly. So there you take the skin graft, and they kind of create like this mesh out of it, and then it's applied to the defect wherever it is, and it's very malleable and movable. So again, it could even be put in the crease of the arm, or it's pretty fascinating. I've always thought that if you were a good seamstress, that you would be good with grafts and things. Um, all right, so let's move. Oh, well, first, uh, let's notice there was something I wanted to bring to your attention about 15100, split thickness autograft. So if it's not an STSG, you don't use this code. And then notice it says trunk, arms, and legs, because the other code is for other areas. And then it says 100, the first 100 square centimeters or less, right? But then it says or, now don't get this confused, 1% of body area for infants and children. And they said, oh, except 15050. So you'd have to go back and look at that code. Now, if I were really working fast, I would uh, I would be going through these codes, looking real quick, thinking, oh my gosh, no, that's only for infants and children. Where's the one for adults? Where's the one for adults? No, it doesn't say adults. You have to get into your mindset. What are they saying? This is a split thickness autograft. They identify what body part they're taking it from, trunk, arms, and legs. Okay. And then they say they do it by square centimeters for adults, 100 square centimeters or less. But if it's a infant or children, you're not going by 100 square centimeters. You're going by percentage, 1%. Right. So again, that could get very, very confusing if you're testing and you're going really, really fast. Be careful that you look at that, the specificity. So the next code is an add-on code, which would say an additional, say 100 square centimeters, and then you start getting into another body area. It'd be slick thickness autograft, and then they would say, head, neck, and something. I can't remember off the top of my head. So pay attention to those details. Now, this is a different type of graft. This is an epidermal autograft, and it's only that top layer, the epidermis. Now, you'll notice in this graphic, what they did was they shaved the area, or they found an area that didn't have any hair. But this is literally, I kid you not, a razor blade, and they are going to take just the top layer of the tissue, top layer of the skin, and they, again, same area that they like to do, thigh, buttocks, abdominal wall, or scalp, and then it's going to be put in on the recipient, and they actually sew this on four corners. They'll tack down the four corners first, and then because this comes out like in a square, and then they'll do like a running stitch all the way around, and it's very delicate sutures. It's sometimes they'll use other things besides the stitches, like they say staples or fibrin sealant. They use that sealant a lot now. I had recently had a procedure done, and I made some comment about the sutures, and he said, "You don't have any sutures on the outside." I was like, "You're kidding," because this is a really significantly large incision. And he said, "No, all the sutures are inside. I use sealant on the outside." Okay, so they glued you. Now, the procedure that I had done, they had to pull tissue together. So there was originally some stitches in there that he took, that left holes, but there was no sutures on the outside. There was nothing there, and they used this really cool tape that they put on that just looks like cloth tape, but it's was really, really sticky, and you had to use like alcohol to get it off. You couldn't just pull it off. So it was, I learned something. I was impressed. So let's look at the description of this code 15110. What makes it different from the other ones we've already talked about? Epidermal. Now it's an autograft. Again, it's coming from you, but it's epidermal. Whenever you see epidermal, that's all they're taking. Notice again the body locations: trunk, arm, or legs. Now, leg means thigh, okay? And the same as before. First, 100 square centimeters or less for an adult, but if it's an infant or for children, it's 1% of the body area. So you have to know that rule of nines, or total body surface area, to be if to be able to understand that properly. Okay, now that means the next code is going to be an add-on code that says an additional 100 square centimeters, most likely, and then you get into epidermal grafts with different body parts: the head, the neck, etc., etc. Right? Very good. Break down the code description, see what's pertinent. That's part of our bat technique. Anything after the semicolon, which you see the semicolon is after legs, then you would highlight that, because that's pertinent information that separates one code from another code. Full thickness grafts, very unique. Can anybody tell what that is when you first looked at it? Does anybody know what body part that is? See if you can, while I'm talking, and you can put it in the chat, because I thought when I first looked at it, I was like, well, I know what that is, but then I looked again and I thought, wait a minute, that might look like something else. Full thickness grafts. What is different about them is that we're taking more of the layers of the skin. We're actually getting into blood supply. So whenever you see full thickness, blood supply is what you're looking for. Again, Denise says big toe. Now, you'll almost always have sutures involved, because they've got to have those that really attached well, because they want to establish blood flow again. Now, when you notice, it's kind of discolored, right? Because their blood supply hasn't kicked in. Our bodies are amazing in that we can reestablish blood flow when you take a piece of tissue from one part of the body and slap it on another, and then it almost makes like this natural scab, and the blood supply picks up. Let's look at the rest. If you're going to do a skin graft, sutures, and they have layered dressing usually, and they usually push in there to give it a little support. They could do bulky gauze. These are all verbiage words that you need to be aware of when you're reading this, because it's just fodder. It doesn't distinguish codes. Or anti-shear layer. I've seen that in documentation. If you use 15200, it's going to almost always be there to repair a defect that has been created for another reason. Not all the time, but not always is it trauma. It's usually they've removed something or had to do something, and then they're putting that full thickness. But not 100%, but that's what I'm used to seeing. Now, what distinguishes 15200 from 15201? That's an add-on code. So let's look at 200, full thickness graft. Okay, that distinguishes it. Free, including direct closure of donor site. Ding, ding, ding. That's important. That means wherever on this image that they got that tissue from, they got to close it. And that means this code 15200, you don't have to use another code to close the donor site. Sometimes you do have to do that. So pay attention. You'll be using more than one code. This is going to be donor site trunk 20 square centimeters or less. So that's the beginning, and then you just keep going bigger and bigger. So again, I had Donna said foot, Denise said big toe, Dia said toe, but actually, no, that's a nose. So look at it again, and the picture actually to get it to fit and to make it big enough, because I wanted you to get to see the sutures. I took the picture that went this way and I turned it sideways. So this is as if you're looking at the patient, looking down at the patient. That's the nose. Delicate work, right? And those sutures, very tiny little individual sutures. Do you know why they make individual sutures and not running stitches? Because if you pop a stitch, it would all come undone, right? And we don't want that to happen. So, and you're probably not going to pop a stitch on your nose, but I'm telling you, a big sneeze and you might. Flaps. Now, what I wanted to look at first on flaps was what's our code range? And it's a pretty big code range, and we're not going to go all over those codes. 15570 through 15738. I mean, we're talking over, like 200 codes. But if I take the first few and we describe what's different in them, then it'll make sense because it kind of repeats itself. So for the flaps, if you look at 15570, that's for the trunk. And then 72 is scalp, arms, or legs. Then 74, forehead, cheek, skin, mouth, neck, axilla. And genitalia, hands or feet. Then 76, eyelids, nose, ears, lips, or intraoral. There is a lot of flap procedures that are done inside the mouth. I was surprised. I went in to find some really good images for you so that we could talk about them. I'm an audio visual learner. I need both. But visual, sometimes, like for flaps especially, it just doesn't make sense to me. I have to see it. And so I did grab some pictures. These pictures are out there for you to look at. And if you're not squeamish, then I would encourage you to go ahead and kind of look at them, jump out to those websites and see some of the descriptions of why they would use this particular type of flap versus another. Now we're going to talk about that a little bit, but for the most part, I want you to just see how the code set is divided up. And that's what I did here with this table so that you could get an idea. It's like, okay, well, I'm seeing now that these codes are divided up by body part and their flaps. Now, this would be stuff that you would see most likely after the semicolon, right? Don't get confused, and because it might say, well, the person had a flap done on the forehead, and then they're mentioning the eyelids or something. No, that's 15574 if that's where the flap was done. Okay. So let's just talk about flaps themselves. What is some information that you need to have in your knowledge bank? One is that sometimes they're multi-stage procedures, especially if you have tubed pedicel flaps. And I've got some pictures of those. And not all the time are they multi-stage procedures, but if they are, then you would expect that. And there may be modifiers that are applicable if that's the case. If you do a pedestal flap, what that means is it remains attached in one spot so that they keep the blood supply. Those are that's verbiage that you're going to see in the documentation. So they just make kind of a tube, a pedestal flap. They make a tube attached from one side to another. I got a great picture from, I think, World War II. I can't remember the particular doctor that started doing it, but you may have seen these pictures before of these military guys, I think they were airmen, that had had facial burns and trauma, and they had made a bunch of called walking flaps. And so that'll be interesting to look at in just a minute. Now, again, the main terms: multiple stage possibility. They remain attached on one end for blood supply. And then you you might see terms like lateral flap edges, and you might see always you'll have the size and configuration of the flap will be documented, and we're going to look at those are like W, Y, Z flaps, V and Y. Uh, that is something that's important to know, because that does also end up being part of the description on some codes. Donna made a point: neurosurgery, scalp closures. Yes, there were several of those. And again, if they have to cut open and do anything to the brain, or they're taking pieces of the cranium and stuff, they may have to do flaps for that. So good point, Donna. And then that last little paragraph, notice that if you have multiple layers, if you have recipient site in multiple layers, that's a possibility. And sometimes with these, unlike the other, separately reportable closure of the donor site. Okay. These are, uh, whereas those others, it's not as thick and not as deep. So whether you have to just kind of, you don't have to do as much to close those up. So it's just bundled in. Whereas these are much more extensive amounts of tissue, and you can't just take a hunk of meat off of you and put it someplace else, whether you leave it attached or not, without repairing the donor site itself. So there are specific guidelines regarding those that surround the codes, and they tell you separately reported skin graft or local flap may be required for donor site, and it'll tell you right there next to the code, you know, code in addition closure. Okay. Now, let's talk about some flaps. One of the newer ones, and this comes straight from Mayo Clinic, was called a pedestal Tram flat. I can't remember what TRAM stands for, but I know I used to know what it is, but I can't remember what it is right now. You can look it up. This is one of the newer ways now that they're doing repairing breasts after breast cancer and mastectomies. They can do both breasts with the abdomen. Ultimately, what they do is they take the abdominal skin and they give you, and they take the fat too. And instead of putting in an implant, they use the skin and the fat to make reconstruct the breast. Otherwise, you have to stretch the skin and put in an implant. Uh, that and some people don't want implants. This would be your own fat, and there's fat in the breast tissue itself. Oh, transverse rectus abdominis myocutaneous. Thank you. Yeah, I wouldn't have remembered that by myself. I had, because actually when I don't know, some of you may know, but a year or so ago, I did have a breast cancer scare because my mother had breast cancer and it's in our family and everything. And they saw something and it didn't look good. And until they went in and did the biopsy, they were pretty sure, that it was breast cancer. And so I just told them, I said, we're making plans. Let's just plan what we're going to do so that we can hurry up and do it right after the biopsy comes back. And if it doesn't happen, then great. If it's not what you think it is, great. But nobody was giving me positive feedback. It just didn't look good. And it was good. It was not what they thought it was. So I was very lucky. But this is the way I was going to go. They take your abdominal muscles. So they don't take the muscle, they take the fat in the skin. So you get a paniectomy, which is kind of nice. And then they just literally take the fat and the outer skin tissue and reconstruct the breast. And if you go and you look at some of these plastic surgery sites that do Tram flaps, it's amazing. They're very, very realistic looking. And they're not perfect, you know what I mean? Because we're not. we don't look like the images that they project out on some of those magazines and everything, but it looks so realistic that it's impressive. And again, it's all your own tissue, so that if you gain weight, they do too, and if you lose weight, they do too, because it's your own fat. So Mayo Clinic has a lot of information about this, and you could do some research. You're going to see more and more of this being done. If you do oncology, then this plastic surgery, of course, but oncology, you're going to have these procedures coming through. So familiarize yourself. Now, backtrack. That's the latest and the greatest that they're doing for breast reconstruction for cancer patients. Now, let's go way back to World War II. This is a graphic, an image that was taken by this one particular provider. And these, I believe I read the article a little bit to refresh me, that these were airmen that had been injured, and these are called walking flaps and tube pedicel flaps. And you may not be able to see, but each one of those men have skin attached to another part of their body. So the the three with the noses, that skin is literally, a tube is attached to the nose and to the shoulder or chest area to keep the blood flow. Okay. And then once the blood flow is established and they know that it's viable, then what they'll do is they'll detach it and they'll reconstruct the nose or a part of the face and give that person a as natural a look as they possibly can. Now, the one gentleman in the middle, he has a tube from, not it's not from his nose, but it's from his chin and his mouth to his chest. There's also images where they have taken flaps and created them and attached them from the hand, like to the chest. So you had a tube from your chest to your hand, because they're going to replace the skin on the hand. And they've done that with other body parts, where they literally attach a body part to you, and you have to go so long with that attached till the blood flow is viable. And it's amazing what they can do. So this was back in World War II. This particular doctor kind of started this process, and amazing. They still do similar procedures today. Not necessarily this type of flap on the face. They've progressed and made it better, but I thought that was a neat testament to what we've had in the past. So now we're going to look at adjacent tissue transfers. What you need to know about this is, a lot of times these are done from traumatic wounds, lacerations, or they've had a um, uh, surgically created defect. And if it's going to be on the face, again, we want it to be as natural as possible. Amazing what they can do. Now, Mohs surgery, when that came out, that was amazing, right? But ultimately, if you're going to have a cancerous lesion taken off of the face, whether it's benign or malignant, you have a hole somewhere on your face. And they can't just close that. So they've been able to do these tissue transfer flaps, which kind of has taken the place of these pedicel flaps. And there's different ways that they do it. They do Z, W, V and Y, rotation, advancement flaps, double pedestal flap. Just all these terms. Don't let that that verbiage scare you. Mainly, it's literally the shape. So they cut a Z, and then they're able to pull it a certain way. It's fascinating. Really skilled surgeons who do this. Delicate work. And what you need to know about the codes themselves. Look at 14020, adjacent tissue transfer or rearrangement. Now, those two terms tend to be, I don't know that they're interchangeable, but every time that you look at anything, an article or a graphic, it'll say adjacent tissue transfer or rearrangement, or it won't even say R, it'll just say rearrangement. So I'm not real savvy as to where, is it interchangeable? Are they two specifically different terms or not? But just know that this code, it doesn't matter what your provider says. If he says rearrangement or adjacent tissue transfer, both are applicable. Then notice the body area, scalp, arms, and or legs, that start with this code, and then after the semicolon, you highlight defect 10 square 10 square centimeters or less. So the type of flap it is, then or transfer, the area that they're doing it at, and the size. So you have three things, components of that code description that you need to know. Now, I didn't make this big because this was a lot of information. I started to not put it in there, but I thought, you know what? This is verbiage you need to know. So again, what they're saying is if you do adjacent skin and subcutaneous tissue is taken, and then they do the tissue borders are all attached. This creates a secondary defect, right? Because it's a donor site, you know. But they don't really call it a donor site when it's a transfer like this or rearrangement. Donor sites are more for verbiage that's used for, hey, I took it from the thigh and I put it on the neck. So then it says that all that surrounding tissue is undermined, and making sure that it's mobile because they're going to twist it and it's malleable. And then they're going to transfer it or rearrange it, you know, to cover the primary defect. And again, great graphics, amazing. They've got like people with holes in their noses, and you're thinking, oh my gosh, how are they going to cover that up? And then they show you 6 months later, and you can't even hardly tell that there's a scar because they're so good at this. Um, let's see, go on, and it states, now look here, secondary defects may be closed with a separately reportable skin graft. May, that's a key term. If it's not built into the code or bundled in. And then it says the primary and secondary defects are measured to determine size of defect. So you put those together. So you use 14020 10 square centimeters or less, and then 14021 if the defect measures 10.1 square centimeters up to 30 square centimeters. And then again, you can look at the codes to see how that's all arranged. It's going to give you the what type, what body area, and size, three things that are pertinent. So here is some examples, and the best example that I like, now these are three different people. Notice that this first one, it shows there's the lesion right behind the eye. Then they show, hey, all the stuff that they had to do to take that out, and that's probably Mohs surgery. Then they repaired it, and they got even into the duct of the eye. And then notice the final version where, you know, just a faded scar. The best one by far is this one here on the right, upper right corner, where you see this almost this S almost written in there, and very tiny, fine little sutures because then you have less scarring. And notice you can't even hardly tell. Now, I've seen the this is C and D. I've seen A, B, and C. I've seen other the full, and but where I grabbed this didn't have it, and it's a big old hole they put in her. And then this last one showing you there's the lesion that they removed on the top of the nose, and then this is the transfer of tissue from one side of the nose over to cover that up. Isn't that amazing? They go up into the forehead and they're able to move that. And when that heals, you know what? And it's even swollen right there because they just did it. You'll never be able to tell that they did it. Just a really tiny faded scar most of the time. It's amazing what they can do. So they will have W, Z, V, and Y, and that's based on the shape that they cut into the skin to make the transfer. And go out and look at how some of these are done, because you think, how in the world? I can see how Y works because it's the V that gets pulled down over the tail, and I can see the V. The Z was and the W were really hard for me to understand until I watched it. So the Z, you have two pieces like this, and they literally just pull them up on top of each other. And the W is the two flaps like this that come together. So the lesion is at the bottom of the W, and so it goes like this, and then these two pieces are pulled in, and it covers up the lesion there. It's pretty amazing stuff. And I think that if you saw some of these pictures, it would help you understand how adjacent tissue transfer is done. Remember, you're just taking a little tissue from one area and moving it to the other area. All right. Any questions? Thank you, Paula. But she goes out of her way to describe the procedure. Yes, because that's how I understand it. So it's how I learn. I hope it's beneficial to you because also visual as well as hearing it described, the little nuances in the codes. If you're not aware how the code description is set up, then it doesn't help you. And also all the components, and they're repetitious, right? Just little nuances are changing. It's usually after the semicolon that changes. That's why the bat technique that Lorene created back in the 90s works so well to be able to do that. And if you're not familiar with that, by all means, go and look at the website for more information. Is there any questions about what we talked about? I'm not seeing any, but thanks, Paula. Our team loves doing this for you. That's why we want you to go and if you're interested in the CCO Club, this is a benefit of the CCO Club, getting all the behind the scenes stuff, the transcript, the slide deck, as well as the video, and an ongoing conversation about this presentation can occur at the club. Minimal investment monthly for that if you want to do that. But again, if you're in the club, put those comments of things that you want us to break down. We're doing these every Tuesday. From here on out, we've been doing them off and on. The only time we take a break from that is if we need to make new content or upload new content, create new recordings for our existing courses. Thank you very much for the kind words that I see popping up there. The team really enjoys doing this for you again, and we hope that you, if you're watching on YouTube, hit the thumbs up button right now, because that helps us, and it helps us go up on the chart system to make sure our content gets out to people who need it, and plus it makes us feel good. And then, excuse me, also, not only do you hit that little thumbs up on YouTube if you're watching there, LinkedIn you might want to share, but subscribe, and that's helpful too. You can hit the bell, and that'll tell you when we've got a video coming up. We do Tuesday, Wednesdays, and Thursdays every week, unless something happens and we need to switch that up a little bit. And again, CCO Club members get heads up what we're going to do ahead of time. All right. I think that's it, right? No, yep. All right, guys. Thank you. I can't believe almost an hour. I was thinking that I'd go through it pretty fast, but we dedicated an hour to this. Appreciate the comments, and don't forget the thumbs up, as well as subscribing, and feel free to share and continue the conversation. By all means, I'll jump out later after I get everything closed down and make some comments on YouTube as well. Thanks, guys.
Do you need more medical certification and business training? Learn more at www.cco.us.